And then PCA pumps. And Helen mentioned this also. They're plagued with design flaws. So, and it's not just one PCA pump. The famous one is the Abbott Life Care pump. And it's the one with the glass syringe, and it's a big boxy one. Boxy but good, whatever. And I saw this one in person after I was in the safety agency. I was working relief at a surgery hospital. Somebody said, oh, we need more OxyContin. And I'm like, no. What's the patient on? The patient was on 5 narcotics. I'm just the weekend pharmacist, right? 5 narcotics and 4 benzodiazepines because they had surgery, they got an internist, this is a surgery hospital, blah, blah, blah. Nobody was in charge of the pain management. And, this one was IV push, this one was, topical patches. I'm like, forget it. I called the surgeon and said, pick a drug and we're sticking with it. Because there's too many and the pharmacokinetics. So we switched her back to morphine PCA and kept, wamping the dose up. This person had gastric bypass, a cage procedure, and adhesion. So she had 3 surgeries in 6 months. She had pain. She was a nurse. Other nurses said, she's malingering. I didn't believe that. So we just kept going up. And then the next morning, I get a call. I'm the agency pharmacist. I get a call. You're the only one that ever listened to me about pain control. She'd been in the hospital a week. Nobody was listening. They all thought, they just poo-pooed what she had to say, right? So she was fine. She was actually got a good night's sleep for the first time in a long time. So, but the Abbott, so while they're programming the morphine, the nurse is standing there with the pump going, and I'm like, what's the matter? She goes, well, I can't get the machine to start. Well, it's this exact thing. There's 2 problems with that pump. Hopefully most of them are out of service now. The one is you turn the machine on, it defaults to 0.1. If I have 5 milligrams, that's a 50-fold overdose because the concentration is 5.0. Not 0.1. If I have a 1 milligram morphine, it's a 10-fold overdose. So there's lots of injuries from that. The second question, it's an obtuse question and deep in the PCA pump. It says, set total dose limit, ? Oh, sure, yes. The real question it was asking was, did you set the total dose limit? So when you hit yes, there's no breaks. So you just answered the wrong question. So, the lady who did the work on this was Laura Lynn from the University of Toronto. She's my dear friend and co-author of a textbook chapter on human factors engineering. And she, as her master's project, because that University of Toronto's got a fabulous human factors department with Kim Vincente. And they redid it and made more logic to it, and the errors got like 60% of the errors got designed out. However, it's not just Abbott that has design flaws. So I would encourage you guys to go to MAUD. How many know about MAUD? Okay. All these safety people here, all these people that are healthcare people, never heard of MAUD. MAUD is the medical device safety database. So what happens is if it's a fluorouracil death because the pump took off, the report will be in the pump database. They happen to have died from fluorouracil, but it was a pump problem. So it gets that safety stuff, a lot of medication error stuff is in MAUD. You just go to FDA, just type in MAUDE. And you can do a search for your diabetes meters, any medical device, you can go and find out the hazards. I was shocked. So when I looked at FDA's MAUD database and typed in PCA, there were 200 reports for various different machines. And we just looked at this. We had a CAD pump. Some of the CAD pumps were in mils per hour. Some of them were mils per 24. Nobody noticed. Purchasing did one of those, I got a better contract kind of thing. And when we finally sat down and looked at it, they weren't the same pump, and we wanted to standardize. So boom, spent the money, got brand new pumps. We replaced the ones that were non-standardized. But that's where I found a whole bunch of patient deaths. There's a lot of data in there, and it's experience from all over. Helen already talked about PCA by proxy a little bit, that we should really have the patients. The safety feature is when the patient falls asleep, the machine stops giving the drug. So if somebody else is still pushing it, you could put the patient in a coma. This is difficult with peds and also difficult sometimes with palliative care, but You know, in general, PCA by proxy shouldn't be done unless there's extremely controlled conditions. And also we try not to have basal rates, because the basal rates are when the drug gets ahead of the patient.